Okay, so we can start the session. Okay, now the very first question was about a chronic alcoholic, and he has left drinking alcohol 3 days back. Now this time duration is very important. So whenever we are solving questions based on alcohol withdrawal symptoms, the time limit is very important. So this person has left drinking alcohol since 3 days. Now what symptoms he has developed? Irrelevant talking and disorientation, restlessness and insomnia, right? So obviously this is a case of alcohol withdrawal syndrome, right? And in this particular topic, the very first thing which you should know is the most common symptom of, we can write it AWS, right? So most common symptom of AWS is hangover next morning, right? So this is hangover next morning. Then most severe symptom of alcohol withdrawal syndrome is delirium tremens, right? So delirium tremens is most severe. And now delirium tremens is seen if a person has left alcohol drinking for about 48 to 96 hours, right? So there is abstinence from alcohol since last 48 to 96 hours, right? So this is the time period for delirium tremens, right? Now the word is delirium and tremens. So tremens means, of course, there are tremors, and then the word delirium actually means acute confusional state, right? This is associated by disorientation, which can be in terms of time, place, person, right? The person might be agitated, there might be hypertension, and there is insomnia as well, right? So these are few important, and yes, of course, we can also add one more, that is hallucinations. So there can be visual hallucinations, right? And there can be tactile hallucinations, right? And it can be like bugs crawling under skin, which you read for cocaine actually most of the time. So this is formication. Clear? So this is a classical case of delirium tremens, right? So here, whenever you see a case of alcohol withdrawal syndrome and the time duration is anything between 48 to 96 hours, and the classical symptoms of delirium, that is disorientation, insomnia in this particular case, so this all goes in favor of the diagnosis of delirium tremens. Okay, so this is how you have to answer this particular question. So the time duration is very helpful for us to reach to the diagnosis of delirium tremens, right? Then moving forward to the next question, and this is also based on the concept of delirium and dementia. So you have to tell the differentiating point between delirium and dementia. Yes, any would like to answer this question? Differentiating feature between delirium and dementia. Would someone like to answer this? Now, before we discuss these two topics, it is there is one heading, that is organic brain disorders, right? So there is one heading that is known as organic brain disorders, and in this heading we discuss mainly two conditions. One is delirium and another is dementia, right? So both these entities, they are discussed under a broad heading, that is organic brain disorders. Now, what does the word organic brain disorders mean? It means those psychiatric disorders which are originating because of some brain pathology, right? So because of some brain pathology. Clear? So such entities are known as organic brain disorders, and again we can have two classes here. One is primary and another is secondary. So primary means there is some brain pathology per se, right? In secondary, there is some systemic pathology which is later on affecting the brain. So this is primary and secondary, right? So this is organic brain disorder. So we discussed two conditions, delirium and dementia. Now coming back to the question, and to answer this you need to know little bit about delirium, and you have to know little bit about dementia, then only you can answer this kind of question. So if we just write dementia on one side and another, right, so if we write dementia here, or better we write delirium first. So delirium, and then here we write dementia, right? Now dementia, I think most of you must have heard about Alzheimer's disease. So that is classical example of dementia. Okay, so whenever you have to talk about dementia, you can think of Alzheimer's disease. Now delirium is also known as acute confusional state, and dementia is actually a chronic brain disorder, right? Now delirium is mostly seen in post-operative settings, ward, you can say post-operative ward, where the patients are already hospitalized, right? Now coming to the features of delirium, one important is in relation to consciousness, right? So there is clouding of consciousness in delirium, right, whereas it is normal in dementia. So this is one important difference between delirium and dementia. There is clouding of consciousness in delirium, but the consciousness is okay or normal in dementia. This is one important difference, right? Now because of this clouding of consciousness, the patient is decreased responsiveness to external stimuli. Okay, so just because of this there is decreased responsiveness, or you can say decreased awareness of external surroundings. So he is not bothered about the surroundings, or he does not respond to the stimuli as such. So this is one important difference between the two. Now the second important difference between the two occurs in terms of the effect on memory. In cases of delirium, there is impaired registration and retention of new memory. This is very important, new memory, right? Whereas in case of dementia, there is impairment of recent memory. Clear? So one important difference is new memory in terms of delirium and recent memory in dementia. Now how we check recent memory? To check recent memory, we can ask the patient what you ate in dinner last night, right? So you can ask him what you ate in dinner, or even like what you ate in breakfast today morning. So just any recent event. Or what you can do, you can just give a address to memorize and ask it after you say 15 minutes. So these are two methods. Commonly we can do these two methods, and we can check for the recent memory, right? So this is very important here. Now apart from this, there are many other features which are specific to these two entities, and they are not used for differentiating as such, right? Like in terms of, if we take for delirium, there is disorientation, clear, to time, place and person, right? So obviously the disorientation to time comes first, followed by disorientation to place, and finally disorientation to person, right? Apart from this, there is also insomnia, clear? So there is insomnia, and it means there is insomnia, okay? And in delirium, the signs are more marked in evening or night time, right? And this is known as sundowning, okay? So this is known as sundowning, clear? So as the sun sets, the symptoms of delirium becomes more prominent, so that is known as sundowning. And then there may be distractibility or poor attention span. So this can be, there can be distractibility and poor attention span. There is one term, and that is known as flocculation. That is bed picking movements, clear? And yes, there can be hallucinations, which are very typical of delirium. So there can be visual or at times tactile as well. So this is all about delirium, okay? Now there are some additional features of dementia. Of course, one is normal consciousness, that there is low loss of consciousness. Then there is impairment of recent memory. Then there is lack of judgment, okay? Then there is personality deterioration, right? So person is not too much bothered about what he is bearing, how he is looking. So personality deterioration, okay? So these are few important points which you should remember for dementia, and these are few important points which you should remember for delirium, right? So this is important here. And now when we come back to the question, the important point which comes out from the options is loss of recent memory in dementia, right? So patient is not able to tell you what he has taken in breakfast or dinners previous night, or if you give something to memorize, he won't be able to remember it even after 15 minutes. So that is, recent memory is impaired in dementia, okay? Whereas in cases of delirium, it is in relation to new memory, right? So please remember this much. Now the next question is about minimal brain dysfunction. Now this minimal brain dysfunction, it is an old terminology, and it was related to attention deficit hyperactivity disorder, right? So this is just one more term for ADHD. So ADHD. Now as the name suggests, I think most of you can just mark out the different symptoms of this entity. So this is attention deficient, right? and hyperactivity. Clear? So when we say attention deficit, it means it seems you don't listen. So seems don't listen to anyone, right? So this is attention deficit. Then it can manifest as can't finish one task, right? So whatever the task has been given to him, he won't finish to that task, and he will switch over to another task, right? So this may be a manifestation of distractibility, right? Apart from this, there is impulsivity, right? So there is impulsivity, and he will jump on from one activity to another, right? And then there is hyperactivity, means he will keep running from here to there, okay? And suppose if he is a student, he will disturb other students of the class, okay? So this is hyperactivity, right? So this is in short about ADHD, and the symptomatology is quite obvious. The moment you have these kind of words, you can clearly make it out as a case of ADHD, right? So there is attention deficit and there is hyperactivity, of course associated with distractibility, impulsivity, right? So and the child often loses things in school. That is also one more feature. So loses things in school, right? And quite easy to make a diagnosis. So this is, previously it was known as minimal brain dysfunction, okay? So this is in short about ADHD. Now there is one method of therapy where we give exposure to the previous painful episode. So re-experience and acting out of the repressed affective thoughts. This is known as Abreaction therapy, right? So this is known as Abreaction therapy, and here the patient is exposed to those painful episodes, and in real time the response is generated as such. So a painful experience or conflict is brought back to consciousness, and the person not only recalls those episodes but also relives the material, the event, and this is accompanied by the appropriate emotional responses. So this is Abreaction therapy, right? So the painful episodes are relived and patient actually responds to those events emotionally as well. So this is Abreaction therapy. Now moving forward to the next question, that is about somnambulism, and we have to mark out the wrong statement about somnambulism. So before we proceed, just let us take a few words about somnambulism. Now this is known as sleep walking, right? So this is known as sleepwalking, and this is especially seen in NREM stage. So patient will get off the bed and he will start moving. Now this time the patient is already in sleep. So if the patient is waken up, he seems confused and agitated, and moreover he won't remember what he was doing, right? So he had no recall or memory of what he was doing actually that at during that moment, right? So there is no recall memory as such, and therefore this is quite obvious that consciousness is preserved during attack. There is no consciousness as such. Patient cannot recall, so he won't remember what actually he was doing at that moment of time. So this is somnambulism, and this is a sleep disorder of NREM stage. where the patient actually get up from the bed and he will start moving here and there, right? So this is somnambulism. Now there was another question about confusion assessment method, that is, in short, it is written as CAM. So confusion assessment method, and if you remember, there is one entity which is known as acute confusional state, that is nothing except delirium. So that way you can just correlate this particular question with delirium. So confusion assessment method, that is done for delirium, and here we are using few parameters, like the very first is acute onset or fluctuating, then second is inattention, and while discussing delirium, I told you that there is poor attention span and distractibility, right? So, and of course, for delirium, the onset is always acute, right? Then there is poor attention span and distractibility. Then third is altered level of consciousness, right? So altered level, this is clouding of consciousness, and therefore the patient is unaware of the surroundings, or there is decreased responsiveness to the external stimuli. And fourth is disorganized thinking. So either 3 or 4 is sufficient here. So disorganized thinking, and how it is checked, like we will ask, tell me whether a stone will float in water, float on water or not, or there are fish in the sea, or does 1 pound weigh more than 2 pounds, or can you use a hammer to pound a nail. So these are few questions which we will ask the patient, and let us see whether what is his thinking at that moment of time, right? So that is to check the disorganized thinking, right? So these are few things which we check in actually confusion assessment method. Okay, so this is in short about the confusion assessment method, and this is done for delirium. Okay, so that is a part of delirium, and we know that onset of delirium is acute. There is poor attention span. There is clouding of consciousness. This is also one more thing, right? So just to write it once again, so in delirium there is acute onset, yes, there is poor attention span. Okay, so these are few points which you should know about delirium, and of course these are checked in the confusion assessment method. Okay, now let us move forward to another question, and here actually what we are doing, we are checking the changes in the physiological variables, especially when the person is exposed to some questions which are related to either an event or a crime for which he is a suspect, right? So what we'll do, we will check the pulse, we will check the blood pressure, we will check the respiratory rate, etc., and these are monitored, and these are actually the physiological variables which we monitor when we are putting a questionnaire in front of the suspect, and this is known as polygraphy test. So a polygraphy test is actually known as lie detector test. So many times you might have heard of this particular word. Whenever a police is investigating a suspect for a crime, they are subjected to certain questions, and the physiological variables are monitored whether they are really increasing when the person is exposed or asks such questions, right? So what we check here, we will look for changes in blood pressure, pulse, respiratory rate, and of course skin conductivity, right? So this is lie detector test or polygraphy. Now next question is about intense depression and misery without any cause specifically in old age. So there is depression without any cause, especially in the old age. This is known as melancholy, right? So this is melancholy, especially related to the depressive episodes in the elderly people, and therefore you will find all the symptoms of classical depression case, like getting started in with the morning routine, right? There is depressed mood in the early hours of the day. Then there is lack of enthusiasm, even after hearing some good news. And there is some statements of feeling excessive guilt, or some statements of despair. So all related to depression in elderly people, that goes in favor of melancholic depression, right? So this is melancholic depression. Now the next question is about delusional disorder, and we have to mark out the wrong statement here. So now, delusional disorder, I think most of you must be knowing, it's a disorder of content of thought, right? So content of thought, and the person, they have their fixed thoughts, right? So they have their fixed thoughts, and so false, unshaken beliefs, which are not even amenable to proper reasoning. So if you give enough evidence to say that, see, you are wrong, they are not going to listen to it. So that is known as delusional disorder. And then I think you might have heard of many delusion. One of the common what we see in case of mania, that is delusion of grandiosity, when the person will say that I am very powerful, or I am very rich person, right? And then in cases of this is of course mania, right? There is another common delusion which you must have studied, that is delusion of nihilism, right? That the world is going to end, nothing is going to survive. That is again a feature of depression, right? So these are delusions. The persons, they have their own thoughts, and even if you say that, see, there is nothing like that, they are not going to listen to you. So that is delusional disorders, right? So if we look out at the options, so false but firm belief which is not corrected even after reasoning, and the person will stick to them with full belief. So that is true. So the answer will come out to be option A, right? So this is in short about delusion. Then the next question is about the phobia, where the person is having fear of darkness, right? Now, to remember this question, I'll tell you one word. If you have heard of nyctalopia, I think whenever you might be studying vitamin A deficiency, you must have heard of this word nyctalopia, which is known as night blindness, right? So this is vitamin A deficiency. Clear? So this is nyctalopia. So the word nyctalo is actually related to night. So similarly, if you have some word which says that there is phobia related to darkness or night, you can call it nyctalo, and then you can add the word phobia, right? So this is how you can derive your answer for this particular question. So this is nyctalophobia, that is the fear of darkness or fear of night, right? Then moving forward to the next question, and again this is from a very important topic, that is mood disorder. Now here a patient is already a known case of major depressive disorder, and he was started on antidepressant, that is imipramine. Now during the course of the treatment, he developed changes which is like excessive shopping, hyperactive behavior, and elevated mood. So now what we need to do? So if we just summarize the question, so patient is having major depressive disorder, right? Started on antidepressant like imipramine, but now he is having elevated mood, spending excessively, and hyperactive. What does this suggest? This suggests that now the patient has entered into mania, right? And this is what bipolar disorder is. There are phases of, mania, depression, right? So alternate cyclical changes. So now the patient has gone into mania, and therefore what the very first step you are going to do, you have to stop this, because there is no role of antidepressant for manic patient, right? So what you will do, firstly, you will stop antidepressant, right? So treatment, first thing is to stop the imipramine, that is antidepressant. Now what you need to do, since the mood is fluctuating, so you have to give mood stabilizer, right? So you have to give a mood stabilizer. Now what are the options we have whenever we are taking mood stabilizers? Either we can give lithium, right? Or we can give antipsychotics. So lithium we have, then we have valproate, and we have carbamazepine, right? So we have these options as mood stabilizers. Now these are all mood stabilizers. And then what actually we do before starting like mood stabilizers, we always prefer to add antipsychotics. So the treatment plan is antipsychotic plus mood stabilizer, right? So ideally we should start as a combination, and once the effect of mood stabilizer sets in, then we can draw antipsychotic. Now what drugs are discussed in this entity? There is risperidone or quetiapine, even haloperidol, right? So we have all those entities here, right? So usually we should start with a combination of antipsychotic plus any of these three: lithium, valproate, or carbamazepine, right? So if you look at the answers from this MCQ, the very first thing is we have to stop imipramine, right? So option C and D is okay, and the further step is we have to start a mood stabilizer, that is of course valproate here. So we have to give a mood stabilizer, that is valproate, and yes, we have practically we do add one antipsychotic as well, right? So antipsychotic plus mood stabilizer is the exact statement, but as far as this MCQ is concerned, we can even go with the option D for answer purpose, right? And in many cases, like we go with antipsychotics alone also whenever we feel that mood stabilizers are not indicated, and if the patient is not able to tolerate mood stabilizers, right? So, and I think for mania, the classical symptoms are quite obvious, right? So if we discuss about mania, you can remember the mnemonic like dig fast. So D is distractibility, I is impulsivity, then G is the grandiosity, that is the delusion of grandiosity, when the patient will say that I am the most powerful person, or I am the most rich person in the world, or I'm just I'm so much powerful, I'm equal to God. So that is all delusion of grandiosity. Then there may be flight of ideas, then there is hyperactivity, that is activity increases, then sleep deficit and talkativeness, right? So this is in short the mnemonic for maniac disorder, right? So you can remember it, dig fast. So here if we broadly classify the groups, so there is of course one is elevated mood, right? So the very first is of course the elevated mood, right? So there can be euphoria, exaltation, depending on the degree of elevation. Then second is, of course, speech and thought disorder. So you can see that there is talkativeness. Patient will talk loudly. There will be pressure of speech. So that is speech disorder. Then of course there can be hyperactivity, impulsivity, distraction, delusion of grandiosity. So that is quite obvious. So there is pressure of speech, will speak louder, right? And then in terms of psychomotor activity, patient will try to do many things at the same time, right? So will try to do many things at the same time. So he will think that he's a multitasker. He can perform many activities at the same time, right? So this is hyperactivity. So, and he will, of course, there will be spending excessive money. He will think that I'm so rich, I can spend too much, right? So this is a very specific set of words or set of symptoms for mania. We can diagnose it quite easily. And as far as the treatment of mania is concerned, we need to give mood stabilizers, and in initial period of the time we should give it along with antipsychotics, and once the effect of mood stabilizer set in, you can withdraw the antipsychotics, right? So this is in short about mania. Now moving forward to the next question. A student presented with breathlessness, palpitations, sweating, and most important is feeling of impending doom. And when you did examination, everything was normal. So this is the moment you find this word impending doom, this is a classical case of panic attack, right? So this is a classical panic attack, and you can see sympathetic overactivity, palpating. This is diphoresis. Okay, so this is panic attack, classical. There was just only one clinical word, classical clue, that is impending doom. Okay, chalo, moving forward to next question. A lady is having low mood. Okay, and it means she is not happy. There is anorexia. This is loss of appetite. Then of course these are all depressive symptoms, and apart from this, she is also hearing voices which are commanding her to die, right? Now this is auditory hallucination. Clear? This is auditory hallucination, and this goes more in favor of psychosis. This is auditory hallucination. She is hearing voices, and apart from that, she is also having depressive symptoms, and this is low mood, which is again very indicative of depressive features. And then this goes more in favor of depressive disorder with psychosis. So we are having both the features of depression as well as that of psychosis, which is manifested in this particular question in the form of constant hearing of voices to die, right? So this is a depressive episode with psychosis. So this is actually psychotic depression, and this means that a person already has severe depression and he has developed some features of psychosis, which may be in the form of delusion or auditory hallucination, right? Or even you can have visual hallucination, right? So this is false belief. We know that this is delusion, and if we see something which is not existing in reality, this is visual hallucination. Okay, and this word, hearing something which is not there, this is auditory hallucination, right? So if you have these kind of keywords in the question, you have to mark depressive disorder with psychosis. Okay, so that is the end of this session, and I am highly thankful to all of you for joining this session. Very shortly I'll come up with another subject. So till then, bye bye, take care, study well.